So now we're going to get down to the real meat of things, and this is the part where we'll have the presentations of the actual on-the-ground country work, and I certainly hope that a lot of questions will come up with the data from these presentations. So our first presentation will be by Edson Araújo, the economist at the World Bank, and he'll be presenting on health labor market analysis for increased understanding of forces driving HRH shortages, maldistribution, and suboptimal performance.
Yeah. So, as Katie said, I'm going to present some result of some recent work I've been doing in the area of health labor market, and just give an overview of what we're talking about here. But I think the main point to emphasize here is this work is a kind of a framework that includes many other different aspects, issues related to health workforce, as has been said here before, and as Akiko mentioned. For instance, this work also includes some work in recruitment retention, where you use the discrete choice experiment, and also include the work on performance, like you're doing some measurement within the RBF project. It includes some work also in education, as Akiko mentioned, that's one area that you are starting to work more, and as well on dual practice, for instance, what we're going to have one of the sessions this afternoon. So what we're going to do now is just a bit of a review what it's about. When they're talking about health labor marketing, what the World Bank is doing about in this area. And I hope in the breakout session we're going to go more in details about this. So I started this presentation with this slide about the health workforce dynamics in Togo, and I think it is highlights on the main point that you want to address when you talk about health labor market analysis. So the point is, as you can see, out of 850 doctors trained in Togo in a certain year, I'm here, out of 850, only 400 are actually working in the public sector. And even more, if you think about the distribution of those, only 150 are working in the rural areas, where 80% of the population is. So the point here is the traditional approach to solve many of the health workforce problems is about training and retraining health workforce and health workers. And of course, this is an issue in most of the countries, as has been said here before. The absolute number is still very low in most of the countries. However, if you think only about training and increase the supply, doesn't mean they're going to increase the access of where they are needed most. So the health labor market analysis tries to understand what is dynamic and try to give some response about how to design policy to address these issues. I mean, some people call leakages and say that we are losing health workers for other sectors, like private sector, do employment or migration. We try to argue it's not necessarily leakage, but it's a dynamic of the health labor market that we need to understand. You know? So my next slide, I try to address some of these points. So what's the health labor market? Now, here you have a health labor market, is a dynamic system comprised of two distinct and closely related forces, the supply and demand of health workers. So it seems to be obvious. So, but also, especially in health, we need to look very much about the counter-institutional regulations. And I'm going to point here how the institutional regulations shape very much the outcomes of health labor markets in most of the countries, especially in the countries you're used to work in low and middle-income countries. So the demand for health workers is the willing to pay for higher health workers. And thinking this way is a good difference, is a step ahead of the traditional think about. Because usually we say that the demand for health workers or the need for health workers is based on epidemiological and demographic indicators, which is true also. But here the point is that the need of health workers is not always necessarily the same as the ability and the willing to pay for health workers. Or in other words, the amount of the resources available to hire health workers. So this is one first step that's important to think about when you talk about health labor markets. Say that not always the need for health workers are going to translate into actual demand for health workers. You know? On the other side, we have the supply of health workers, which is the number of trained individuals willing to work in the health sector. Again, this is another step ahead of the traditional thinking, because it doesn't mean that necessarily is the number of trained people that are supplied to health work, but the opposite is the number of people who are actually interested in work in the health sector, because of many reasons. One of them, of course, is the level of salaries. So if I go back to my slide about Togo, you can see this here. You know? One side, of course, we're not talking about the demand here, but you can see the supply, not necessarily the number of people trained to train as health work. So this is a a graph from a paper we recently published in the bulletin of the special issue about health, human resource for health. And this gives an overview about what we're talking about in terms of health labor market. Of course, here in this short presentation, I just talk about supply and demand and the HR overall employment. But as I said in the beginning, this also includes other aspects of the health labor market: education, geographical distribution, sectorial distribution, performance. All this is also part of the analysis of health labor market. And we've been working together in some of these areas. What the traditional labor economics and traditional labor market analysis can tell us about the functioning of a health labor market. So if you take a basic notion of from labor market analysis, now well-functioning labor market, wages and compensation act as a mechanism whereby intention of buyer and seller are reconciled. So labor markets are said to clear the supply of labor match the demand for health work, demand for labor. So this is the price mechanism. No? So this is a basic notion. But, okay, what's important for us here in health, and we talk about health labor market, is whether this is happening or not. So, and why it doesn't happen. One point is the health labor market failed to clear, failed to demand and supply, failed to adjust, because they exhibit either labor surplus or labor shortage. Sorry, this is an outcome, of course. When the supply and demand doesn't match, you have either shortage or surplus unemployment. So the market fails to clear either because prices are not flexible, demand and supply does not adjust to price signals. So, and that's the point I was trying to make here, that is, we need to look at this condition in the health labor market. Why this demand and supply, why price, and why doesn't regulate demand and supply. No? I'm going to give some example why, and I hope we can discuss this also. So this is the classical condition. You don't have labor supply, labor demand. Of course, as I said at the beginning, this is a very basic notion of labor economics, but we also understand, as I said before, you need other aspects to look, because you don't want to only have full employment, but we want to know also where the people are working, because if you look at the graph from Togo, you're going to see, oh, you have full employment. There are some people unemployed there, but the question also for us in health specifically is whether these people go, where they are working, in terms of private and public, if they migrate or not, and also how their performance in they do, the activities. So why market fail to clear in health, in health labor market? That's the point we are trying to address here. So I have some few points here. For instance, demand for health workforce is derived from demand for health care. And we know that demand for health care have some information problem, because the doctor, the health worker, they act as agents for patients. So patients, consumers, if you think, cannot choose the services, they have to rely on someone else, in this case, health workers. So it adds some uncertainty, some information asymmetry in the demand for healthcare itself. So given this condition, we need to ensure that health workers are providing the care and the service and the medicine that are really needed by the patients. So for that, we need a regulation for health professionals to assure the quality standard in health. So it results in some rigidity. It results in rigidity in the sense that wages are usually fixed by legislative process or tied to civil service regulation. I go to the supply because I think they are a kind of both. You can go back to this point. So again, since you have this asymmetry of information in the healthcare and the demand for healthcare, you need also to make sure that the health worker has the proper qualification, the proper competencies to practice. So you have license, certification, accreditation. You also have a restricted entry, so you have a restriction to input substitution. For instance, in my home country in Brazil, nurses are not allowed to prescribe medicines, because that's only doctors can prescribe. So this is a kind of rigidity that you find in the supply of in the health labor market. So you have a ration of medical school slots, and supply decision made in response to market signals, like geographical distribution, special choice, may not reflect consumers or social values. That's a good example here is about the choice of specialty for physicians. I mean, in most of the country work, you have an oversupply of people, of doctors or specialists, pediatrics, orthopedics, anesthesia, cardiologists, etc. You probably have a better list than myself. So this is a clear point here because the choice for specialization not always guided or by the social needs or by the health needs, but actually by the market signals. If people are choosing certain types of specialization and not going to be a GP, it means that there are some incentives in the market that gives people expectations, either in terms of salaries or in terms of working conditions, in terms of increasing knowledge. They attract them more to these specialties. So, and the point is, the supply decision in health is not always guided by this, either health needs or social values in this area. So then I come back to my graph, my first graph from Togo, and then you can see here how the rigidity that let's call like this, rigidity from the demand and from the supply side, influence the distribution of this, of health workers. So, and again, the main point here is that you need to think about what's happening here, what's the incentives for this. And that's one of the measures you get from the DCEs. That's one of the aspects of the health labor market is why health workers are not going to rural areas. You have, through the DCEs, we can understand more about the preference for employment. I'm not going too much because we're not going to talk about this. But this is, I think this is a good graphic of showing that why the health labor market perspective is important to observe the dynamics of health workforce employment. So very quickly here, result that market signals may result in suboptimal allocation of labor, and here that's clear, suboptimal allocation of labor. Out of 850, only 150 are working and providing service for 150% of the population, those who are in rural areas. So, but why this happen in health? Because constraint maximize behaviors, as you just went through, and also rigidity in price. Rigidity in price, I gave an example about pay for performance. I believe we're going to have a session here. So sometimes it's difficult for government to implement pay for performance schemes because when they go to implement, if they want to change the pay for the health workers, they have to change the payout for teachers, for drivers, for et cetera, et cetera. So it changed the whole, and they have to change the whole pay scale on civil service. So this is a restriction here in when you try to implement pay for performance. This is an example of rigidity in health labor market. So other examples are the compulsory government service. Some countries have to either practice in the rural areas or practice for 2 years in a certain given time in public sector. Regulation restricting labor substitution, as I mentioned, some countries, nurses cannot prescribe medicines. And as I just mentioned about the civil service employment rules, sometimes it's difficult to implement some bonuses or incentives for health workers because you need to change the whole pay scale. So concluding, applying labor economics framework to analyze labor market for health workers helps to understand the diverse and the interrelated constraint affects HR. And I think my graphic in Togo shows about these constraints and these dynamics. The impact on health policy on HR, like for instance, what's the impact of universal health coverage policy on human resources, on health workforce? And the employment dynamics in the health sector in this relationship with economic cycle. And just really to finalize, and that's my last statement here, one of the work we're trying to do, and I think Akiko mentioned this during her initial remarks, is we need to understand also health sector as an employment sector. Now, you see, this graphic, of course, is for ACG, the developed countries, but we can observe similar pattern in low and middle-income countries, where the majority, not majority, but a large proportion, a large share of the labor force is actually in healthcare. You see here from 20% in Norway or Sweden, but in average in OECD countries 10%. And I just bear in mind that you're going to find the same in most of the countries where you was to work. Another aspect is, again, to understand the health workforce and the human resource for health, not only as a service delivery, but also as an employment sector, is the importance to look at what the relationship between employment in this sector and the economic cycle. This is graphics about the US. Of course, US, the health system is different for everywhere else, but it shows us there's a pattern here. Even during the economic crisis, when the employment and overall employment went down, the employment in healthcare kept increasing. The question whether it's good or bad is another question, but we know this graphic shows that it's an important employment sector. No? So that's another area that we're trying to work to understand this pattern in low and middle-income countries. And this is really my last slide. So one potential reason that always the framework from labor economics and health economics in general hasn't been applied to health workforce, human resource for health analysis, is the lack of data, especially on earnings, because as I just showed my graphic, and about when you try to use labor economics framework, the role of wages is very crucial, to understand the wage, how it is influencing people's decisions. Of course, we know that in health, wages are not the biggest determinant. You have many examples. We can discuss this later. So wages are essential to do this analysis. However, we understand that wage is not the most determinant to labor and demand in this sector. So, but the point here is we need to improve the data sets. Improved data sets are essential starting point that will help you to gently move beyond counter health workforce and some of the basic characteristics. So that's usually the data we have to analyze health workforce, administrative data, some registry from association, medical association, nurse association, etc. But this data basically allows to counter health workers and some basic characteristics. So we need better data to understand the determinants and solution to labor market disequilibrium, as was shown in my Togo graphic. I believe that we're going to be similar in many of the countries that we work, and to use high-quality descriptive and causal evidence. I'm not talking about the types of analysis we do when you analyze health labor market, but in the breakout session, we're going to go more in detail, so I already have said what we're going to do. So, and to finalize, we need more data to analyze this labor market. And in the World Bank, we are now working with our labor economists and people working in labor force surveys, household surveys. We are doing inventory of the survey to say, okay, what information we have about health workforce? What is available there? And let's see if what's available is enough to do some basic analysis. If not, let's move to outline a key set of data that's necessary to do this kind of analysis. I mean, besides the work you're doing in the World Bank, I understand there's some working groups. There's a working group on data. I mean, as we mentioned here, there's some initiative around the Global Health Work Alliance. And they'll be working close again with the CapacityPlus, World Health Organization, ILO. So we'll need to get more data to allow us to understand the dynamic of the health labor market. For instance, the dynamics of what's happening in countries like in Togo. So that's it. Thank you.